The second component of this project is social inclusion, and that is actually telephone circles where the elderly call each other, and in this way they support each other. They also link the elderly with who need assistance or care with institutions, and this way helps the elderly to actualize their rights. The third component is mental health of the elderly, where we measure the symptoms of depression prior to the beginning of the project and after the beginning of the project. So this is in brief before we go on to the results of this research. Today we will be discussing on informal caretakers. What describes the informal caretakers is exactly what the former First Lady of the United States said, and that is that there are four types of people in the world. First, who used to be caretakers. Second, who will be caretakers. Third, people who are now caretakers. And fourthly, a group of people that will need care. And this is why we did this research of the mental health among the informal caretakers. Now I'd like to ask our dear colleague, Nevena Sovic from the Population Fund of the United Nations to greet us on behalf of the Population Fund. Thank you very much. Dear Natasha, dear Professor Stanislavic and Milic, dear colleagues, it is my great pleasure to greet you here on behalf of the Office of the Population Fund of the United Nations. And it's my great pleasure that the reason we are meeting today is the completed research on the mental health of informal caretakers. Like Natasha said, Population Fund has a long-term good cooperation with the Red Cross of Serbia. For years, we have been working on research on the positions and the conditions of life of the elderly, and this is all to formulate recommendations for improvements. In cooperation with the Office of the Commissioner for Equality, we looked into the needs of the elderly in the villages and in big cities. We investigated violence and digital involvement. This year is different from any other year. The COVID pandemic caused great changes in every aspect of our lives, but from the first day, we saw that it hit the elderly the hardest, both directly through the consequence to their life and their health, but also indirectly through the effects that it has on economy and public systems, on the social status, and also the social relationships. The effects in Europe that we saw through research showed that 88% of deaths due to COVID were in the elderly population. Some of the assessments that we have also together, that we've researched together with the Red Cross colleagues, showed that there's a difficulty in accessing healthcare services not related to COVID and to social protection services. There's an increased risk of violence, especially financial violence. There's a strong impact on mental health, and there is an increasing need of psychosocial support. This data shows that it takes a lot more engagement on all the levels on improving the position of the older persons. From the beginning of this epidemic, together with the Red Cross of Serbia, our office supported the most vulnerable group of elderly through the lines for psychosocial support, hygiene packages, advice for preservation of physical and mental health. We continued with the support of the German government, together with the Red Cross and some other partners in implementing different activities that promote mental and physical health of the older persons and facilitate the use of digital technologies and promotes the intergenerational exchange, which is even more important at this time of pandemic. Our regional office for the Population Fund, together with the Economic Committee of the United Nations for Europe and the World Health Organization, and the Office of the High Commissioner for Human Rights and Healthcare International, which is the affiliate of the Red Cross of Serbia. On 1st of October this year, which is the International Day of Elderly Person, launched a joint program for the elderly. This program is aimed at improving the rights and the living conditions of the older persons through improvement of the services in healthcare and social protection areas, in the conditions of the pandemic, but also in general, but also through the change in perception of the citizens on getting older and on the older person. Serbia is one of the first countries to take part in this project, and the Population Fund, as the leading agency for demographic and population issues, will continue organizing activities relating to the support of the elderly within this project. To achieve the best results we can, we will continue with the multi-sectoral approach and our cooperation with the international donors and our partners, especially the government of Germany and the partner organizations within the United Nations, including the UNDP, together with a system of coordination that is under the guidance of the Standing Commissioner of the UN for Serbia. The population getting older is a global phenomenon. Getting older is a great achievement of a society and a great resource of a society, but it also does come with challenges and needs for adjustments and creation of conditions that will allow this resource to be best exploited. Of course, one of the most important bits is to provide long-term care for the elderly who need it. Many elderly persons have the only support they get is from their families. In some households, those who are caretakers are also older persons over 65 years of age, which makes the challenges they face even more complex. In Europe, it is considered that there are about 100 million informal caretakers and that they provide 80% of all services of long-term care. 2/3 of informal caretakers in Europe are women. In our country, we don't have the official statistics, but there are some indirect assessments that at least 80,000 people in Serbia have the need for long-term care. And here we also have women as primary caretakers, sisters, wives, daughters. Providing care has a big impact on both the person providing care and the person receiving care or depending on the care. For caretakers, provision of care impacts their time, their physical and mental health, of which are very rarely discussed. The challenges that the elderly and their families and their caretakers face are very numerous. And I'm glad that we will have a chance to emphasize this aspect of mental health and the related needs of the informal caretakers. So I'd like to invite you to hear the main findings of this research and then to discuss together how we can improve the position of informal caretakers in Serbia. Thank you very much.
I would like to thank Nevena Sovic. It's clear how well we have a cooperation in principle, and we're actually repeating a lot of things. And thank you very much for mentioning Health Agent International. Unfortunately, we cannot talk about this conference to mention everything and everyone with whom we have been cooperating for a long term of years. So let's start. When we're talking about informal caretakers, I would like to mention the definition. An informal caretaker is a person that offers constant care without compensation, either to a family member, friends who need it, who need support for physical, cognitive, or mental problems. It is very important to know that there is a problem because often we see informal caretakers or family caretakers. But as Nevena said, between 70 and 95% of the total services of care are given by informal caretakers, and they represent the basis both of the social and health system. And in the end, They're basically a blind spot of public policies. So that is why we ordered this research for them to no longer be a blind spot. So this encompasses four fields. The first is daily activities, washing, helping, going to the bathroom, feeding, and so on. Then daily instrumental activities, daily work in the house and transport, and also psychosocial support. And in the end, health services and healthcare. Just a moment, please. I apologize for those who I forgot to begin the presentation. Nobody reminded me, but that happens when uh, when technology takes over. Concerning informal caregivers, a third of the population are over 50 years of age, and they provide some formal and informal care services. Women are more dominant in the population of informal caregivers. About over half of informal caregivers provide services for less 10 hours or less per week, and under one fifth provide services for more than 20 hours per week. What is the increased risk for informal caregivers is unemployment. In comparison, obviously, to their peers who do not provide any informal care. So, in our research, we also had a portion which was directly dealt with informal caregivers during COVID-19 pandemic crisis. In the very beginning, and not just Serbia, but all of the countries have missed to recognize the importance of the role of informal caregivers in situations of care and needs. Of functionally needy persons are also persons who are sick, and also persons who have been afflicted by COVID-19 or who have been suspect of being COVID positive. During the pandemic, we had a new category of informal caregivers who have been offering care to older people who were not functionally dependent or ill, but because they were prohibited from leaving their homes, they had to be given support and care for those older people. As it was already said, informal care was a pillar of the health system for the support for people with any type of health problems, but also the pillar also of the social security system, because either the services were completely stopped or were reduced. For example, care for older people or people with disabilities, so that total encumbrance of the total system, because the services were reduced not just in the health system but also the social care system. Carers UK organization in the United Kingdom said that 81% of informal caregivers provide more care services than before the lockdown, and 78% reported that the needs of the person they cared for have significantly increased. 64% had no time to take a break over the last 6 months, and 64% reported worsened mental health. And when we talk about mental health, we did do a research of the mental health of informal caregivers. We researched burnout syndrome, depression, and so on. However, providing informal care can also have diametrically the different results on mental health. That care can also create satisfaction and also psychological satisfaction, because you're helping a person that you're loving and you're enabling them to have a significant life. But informal caregivers in general have a lower and worse psychological and physical health than people who do not give informal care. In situations where care, in a case when the informal caregiver perceives the person that they're giving care for, when they see him as manipulative, that's even worse. Also, for older people and also for informal caregivers, social inclusivity has a very important influence on mental health. Uh, the greatest risk when informal caregivers are concerned are those who are unemployed, those who do not have any life partners, without any social support. Those are the most groups which are most significantly at risk. When we're talking about the common symptoms of caregiver stress, depression, to is withdrawal, insomnia, trouble concentrating, also includes anger, uh, anxiety, using of alcohol and other substances, and also altered eating habits. Both basically informal caregivers give up their healthy lifestyle habits. So the goal of our research was to measure the influence and the effects of informal care on mental health of informal caregivers, and based on the results, to provide recommendations for planning and developing public policies in order to directly improve the quality of life of the informal caregivers and their mental health, and to indirectly improve the quality of the care and also the quality of life which the informal caregivers are caring for. So the sample for our research was stratified. We had 798 participants in 41 different municipalities. Actually, we had more participants, but these were questionnaires which were entirely completed. The questionnaire had 9 sections. Most of the sections of the questionnaires uh, research sociodemographic characteristics, general information about the person which is receiving the care, the functional status of the person receiving care, caregiver burden, depression, fatigue, health and functional ability, social support, and in the end, had the portion which related to COVID-19. The qualitative research was done in 3 different municipalities, Novi Sad, Pirot, and Belgrade. We had 32 participants, 29 females and 3 men. And and just one piece of data, one person out of the 32 said that because of the problems with mental health during care given for their mother, went to the psychologist or psychiatrist to fight with their feeling of guilt. None of the other 31 participants did not address a professional, nor did they ask for psychosocial support because they believed that it is not okay to ask for support. So only one person had the strength to ask for help for their mental health. Considering the results of the research here, we can see the most majority were women, 71% females, women, and 29% men. It's comparable to the data in the EU. It's 69% of informal caregivers in the EU are women. A larger portion is in the USA. There's actually an increasing number of men. It's about 40% of informal caregivers in the United States are actually men. And that can be explained by the changing the structure of the family, less children. So now even men also are giving care to their older parents or their disabled children. The average age is 54 years of age, mostly people who are working or active, 73%. The oldest informal caregiver had 95 years, and the youngest informal caregiver was 18. We are talking about an image. It's a woman who is 50, 55 and over. However, we have to keep in mind about all of the differences of informal caregivers. We have to keep in mind young informal caregivers who have to be go to get their education, have to establish their own families, and this burden of the care can influence their mental health on one side and also on their future life on the other hand. Research in Austria during the COVID pandemic demonstrated when we're researching informal caregivers for women, about 4 to 5% of them in the sample were actually informal caregivers to older parents, and the average age was 12 years of age. So we have to keep in mind about those specificities of different caregivers, just as those that we found in our sample who were younger. The marital status, most were married, that's 59%. Regarding specific characteristics of caregivers, mostly are people who have a secondary school, 55.8%, and 47.1% were employed. In terms of age, the characteristic of the person receiving care, cared by the informal caregivers, we can see the majority of informal caregivers in the category between 75 and 84 at 36.3%, which is in line with demographic trends because we have old people living longer, but we also have a greater dependency. So we can see that that is in line with the data of the entire world. And in terms of the gender of the caregivers or the persons who were receiving care, 60% were women. The next slide, I would kindly ask Natasha. Okay, thank you.
Thank you. So, to continue, I'd like to say a few more words about the characteristics of care and about the assessed burden on the caregivers that we found in our research. Namely, most of the informal caregivers reported the length of care of 1 to 5 years. 70% of informal caregivers have been providing care up to 5 years. About 20% of the informal caregivers reported the length of giving care longer than 10 years. As for living together with the person they're giving care to, 67% of the informal caregivers reported that they live in a shared household with the person receiving care. As for the frequency of care, majority of informal caregivers, almost 80%, reported everyday care that they provide to the persons who need that care. As for daily duration, almost 50% of the respondents reported daily care of up to 12 hours, whereas the other half reported care longer than 12 hours per day, which can be interpreted as providing care for the entire day to persons who need it. As for the relationship between the informal caregiver and the person receiving care, over 90% of informal caregivers report that they provide care to a person who is their relative. This relation is almost 50% providing care to their parents, and then some other blood relative in about 30%, and in 13% it's the husband or wife, and a little bit less than 10% provide care to their daughter or son. As for support in giving care, almost 70% of informal caregivers reported that they provide care on their own. As for financial implications of provision of care, about 55% informal caregivers reported that they don't have sufficient financial funds to meet the needs of the person they take care of. And they also report that they don't have any financial assistance to provide for the needs of the person they care for. In this slide, we showed the assessed level of demand of how demanding the care is on the scale from 1 to 10. This slide actually provides the degree of difficulty in the responding population of this research. And we show that almost 30% of the respondents reported a high level of difficulty of care for the person they're taking care of. On a scale of 1 to 10, this is the degree of about 9 to 10. So almost a third of care persons receiving care uh, have a very high difficulty of the care they need to receive. 7 to 8 on the scale of 1 to 10 is 26%, and 25% is over 5. So the majority of persons receiving care in this population are actually very difficult to take care of. This slide is something we need to pay a lot of attention to, especially when we're creating recommendations and public policies that pertain to this population. We also looked into the basic and instrumental activities of everyday life of the persons receiving care. On the left slide is the degree of dependence of persons receiving care in performing basic everyday activities, which shows that 60% of the persons receiving care depend on their caregivers for bathing, a little less for putting their clothes on, then moving around the house and using the toilet and continence. And the fewest cases are for feeding. On the right hand side, this is the score of the basic activities of everyday lives of the persons receiving care, where we see that 27% of persons receiving care have the highest level of dependence on this scale, which goes from 0 to 6. On the next slide, we see the level of dependence of persons receiving care in performing instrumental activities of everyday life. This slide shows that there's a high level of dependence on the persons receiving care from their caregivers in performing instrumental activities, which mean taking care of finances, maintaining clothes, cleaning, housekeeping, preparing meals, purchasing food, and use of transport. On the right-hand side, we have the score for instrumental activities of everyday life, where we see that the highest level of dependence on this scale, which is 8, is attributed to over 30% of the persons receiving care. So these two slides that talk about the basic and the instrumental activities of everyday life and of the persons receiving care show that this is a population that has a relatively high level of dependence from their caregivers. The next slide shows the support in providing care. So 72% of caregivers report that they have some kind of assistance in providing care, whereas the right-hand side of the slide shows that uh, the most assistance they get is from the persons who are close to them in over 60% of cases, whereas humanitarian institutions and public institutions are only uh, take up about 8% of providing support and assistance to informal caregivers. This slide shows the responses to the questions that relate to providing informal care during the epidemic of COVID-19 in Serbia. The slide shows very well the most frequent needs of informal caregivers during the provision of care during the epidemic of COVID-19 in Serbia. We can see that the greatest need is for personal protective equipment. The informal caregivers then report that they also need information and some relief services and some other types of services and assistance in providing informal care. They also need hygiene items, they need psychosocial support, and a little less meals, psychological support, and online educations. The right-hand side shows the level of concern among the informal caregivers, both for their own and for the health of the persons they provide care to during the COVID-19 outbreak in Serbia. All three questions received an answer on the level of concern that exceeds 60% of respondents. Informal caregivers during the pandemic of COVID-19 have a lot more fear for their own health as well as the health of the person they're taking care of. They also believe that now their health is more at risk compared to the period prior to the pandemic. And they also think that their own health is more at risk compared to the pre-pandemic period. So the level of concern is fairly high, both for their own health and for the health of persons receiving care. The next slide shows the burden on caregivers. This was estimated by using desired burden interview, which is a specialized standardized questionnaire for the assessment of the burnout syndrome in informal caregivers. We use this questionnaire in our research, and on this population, we estimated that about 40% of informal caregivers have mild to moderate burden, as assessed by this interview, whereas 26% of informal caregivers have moderate to severe burden, and about 6% have severe burden, or a high level of burnout syndrome in terms of providing care. The next slide shows uh, the level of depression and fatigue among the informal caregivers. You can see that there is a very mild level of depression in 11% of informal caregivers, whereas moderate depression is seen in about 9% and severe depression in about 7% of informal caregivers in our population. In addition to the Beck's depression inventory, which is again a standardized specific questionnaire for self-assessment of depression in a population, we also used another scale, which is the group fatigue scale, which looks into the fatigue severity scale of informal caregivers in providing informal care. On the right-hand side, you can see all the questions that relate to fatigue in the group fatigue scale, and we can see that about 30% or over 30% respond affirmatively to any of these questions that pertain to the presence of fatigue in providing care. This fatigue relates both to disruption of work and family life and social assistance. It also pertains to fatigue that decreases motivation for providing care and work in this field. After all of these assessments, both of the mental and the physical health of informal caregivers, we did a multiple regression analysis, which is a model based on which we can give some recommendations in creating public policies so as to decrease the burden on informal caregivers in providing care. In this model, the variables that were significantly had a significant impact on the level of burden were the following: self-assessed health of the caregiver, the more severe the health issues, for their own health, the bigger the burden on the caregivers. Degree of difficulty of providing care and the degree of dependence in providing primarily the basic activities of everyday life of the person receiving care also affected the level of the burden among the informal caregivers, and insufficient financial means as well as the duration of care on a daily level also had an impact on the level of burden of informal caregivers. After identifying these main characteristics, both for caregivers and for the persons receiving care, in the hierarchical regression analysis, we looked into the impact of providing informal care during the COVID-19 epidemic in Serbia, where we also had significant among the variables that pertain to the burden of caregivers. These variables were, first of all, need for psychosocial support, the general need for support in providing care, as well as the need for respite or the respite services during provision of care, as well as increased fear for the caregiver's own health and the health of the person they're providing care to. These were all important predictors of the burden on formal caregivers during the provision of care in the epidemic of COVID-19. Now, since the purpose of this research was to see the mental health of informal caregivers, in our further analysis, we looked into the level of burden of the caregivers with self-assessment of depression, fatigue, and the quality of life of informal caregivers in Serbia. And what we found was a very high correlation between the burden on the caregiver and the Beck depression inventory, as well as the group fatigue severity scale. And also the level of the burden of caregivers with the score of physical health and the mental health that were assessed using SF-12 questionnaires for the quality of life. Based on all of these results, we created the recommendations that relate to the population of informal caregivers, primarily during the epidemic of COVID-19 in Serbia. And you will hear a little more from Natasha about the recommendations themselves.
It won't be Natasha. I apologize. Unfortunately, Professor Dr. Dana Stanislavich is not here with us, unfortunately, but there is another researcher who worked on this research, Dr. Milutin Vracevic from the Red Cross of Serbia, who will be presenting the results, following which you can ask us some questions. The results will be concentrated The recommendations will be concentrated. We will not be giving all of the recommendations. We will most probably translate the book, the publication into English, so you will be able to receive it in the Red Cross of Serbia. Obviously, when the translation to English is finished, we will upload it on the website. So Dr. Vracevic will be addressing. Thank you very much. Just before we start regarding the recommendations, what's important to hear to what Natasha said before me, it's important to understand to what extent informal caregivers are a heterogeneous population on one hand, and on another hand, the burden, which is the key predictor of their problems with the mental physical health, is something which, permit me to say, it's not the same with other groups of caregivers. Depends on whether they have 18 years or they have 30, 40 years, and same time they have an employment or they have a child, or perhaps who is or is not in school, and somebody who is 70, 75, who gives care to their family member. So the differences in those different types of caregivers are different. They're not the same. The level of support that they need is not the same, and how we need to design public policies. That heterogeneity needs to be taken into account for those measures to be efficient and in the end of the line so that they can help somebody. What's important to say, most of informal care in terms of caregiving are given by family members, informal caregivers. So we need to formally recognize them in different laws as partners who give care, and that formal recognition for them would increase their access to rights and social support, and but also in working labor law. What we do know is that informal caregivers have a greater chance of being unemployed if they're in working age, which obviously gives an additional burden and also additional source of stress, and also can be predictor of bad results in terms of mental health. So measures such as, for example, greater number of free days or vacation days when they have to care for somebody, or to have a more flexible working hours so they can help the person that they're providing care for. Of course, there are obviously different perceptions of work, and also for providing care, which is needed. Another thing which is very important, or most important, is the development of a unified system of long-term care. We now, unfortunately, we do not have it unified or fragmented into three systems: social support, health support, and also pension support. In terms of those services, you have to go to five different systems, five different doors, in order to actualize or realize all of the legal rights that you have. So what we are advocating for the users is to have one entry into the system, and based on their needs, to have services from different systems available. That's on one hand. And on the other hand, what's important is to have a wider specter of services of long-term care, especially what Natasha mentioned, in terms of informal care, in terms of care of respite, greater number of nurses, so that people will be able to work. What we need is greater investment in services for long-term care. And that's today when everything is being looked at and being measured in the context, especially me- medical protection as a cost, as an expense, so that we can have greater support, greater protection for the population deals with care, to have them be better health, to actualize their rights, and at the end of the day, to be able to be competitive on the labor market. So in order to have better services of care in the long term. What's also needed for informal caregivers Also, support services, as was mentioned previously. Not everyone needs all of the same services in our times. We have a time of customization of everything. So there is no reason for this type of services not to be customized to people who have different needs, especially relating to training, which they need to support for caregiving. So if you're doing a job or if you're working, you're doing something which you do not know, which you're hacking along the way, is an additional source of frustration. Not only that you will be putting at risk the person that you're giving care for, but also your health. So training which relates to the techniques of care, psychosocial support, social support, respite services, as we said, daily center services. So informal caregivers, on one hand, have to have regular systematic checkups so that their health can be controlled to a certain extent every year, and that way it would be makes sense for them to intervene with different health services and also economic services. What exists already in Serbia, which we enable, is from the pension system, the assistance. On the one hand, we need to increase the scope, but also what is important is that economic services or conditions have to be help or actually a motivation to the employers for people who give informal care is to give them greater flexibility of their labor contract. And also, these recommendations relate to the fact that no country in the world, no matter how developed their social and health system developed be, a great portion of the care will fall on the burden of the family. And at the end of the day, that's not even that bad. What is important is that care, if the care does not represent the great burden and does not dramatically change your everyday life, it is a source of satisfaction because you're helping somebody who's a close family member or friend so that they can function normally. So I believe that we need to increase this type of cohesion which you have in this society, and certain services have to be given by this society, but different also have other services which will be given by caregivers, informal services provided by the NGO sector. It's a part of one big puzzle which represents uh, the system of informal care. Next slide. What is specific to the situation with the pandemic of COVID 19 is the fact that we have two different existential risks in front of us in terms of informal care. Makes the thing a bit more dramatic. On the one hand, you have risk to your own health and to the person which you're giving care to, and also have a different existential risk, which is a type of economic risk because of the great unemployment, which is a consequence of the COVID 19 pandemic. And in that sense, you have things which, on the one hand, seem evident but are not obligatory, is that people have to have clear information, which means that you have a heterogeneous population. So, clear information are not clear information to somebody who has a medical education or somebody who's a layperson. So that information has to be adapted to different groups of people and in context of their different risks. An informal caregiver has certain risks which are not inherent to a person who is not. And also access to medical protection, medical protective equipment, uh, what does not sound like a dramatically great expense for us, for protection, for reduction of risk, needs to be greater. That expense might be significant for those people. So it is needed for them to have access to protective equipment. What we can predict is that they might have increased mental problems, is also to give them increased access to mental health services. For example, access through phone or different applications. What's important is that access needs to be given to everyone. So if you have an app, you believe that if you have an app, you think you will resolve everything. A lot of people, especially informal caregivers, do not use digital technologies. So support needs to be accessible to all. So you have to have it in different formats and shapes. What's also important is the manner in which we do things. For example, support networks inside of the population of informal caregivers, in order to, on the one hand, for them to be clear that they're not alone in this boat, and on the other hand, also to get advice which they might not have from somebody who is simply studying that phenomenon, as opposed to somebody who is living through it, who is finding hacks and shortcuts in that situation in order to make care more simple and easier. What's also important is to keep in mind, because of the pandemic, what seemed is not such close future, which is telemedicine. And now it's clear that we have to invest much more of it, and it needs to become part of the package of standard medical services of any system which pretends or hopes to be efficient. And it's not bad to start thinking about that right now, how these telemedical services can be developed. And last thing is the continued education for informal caregivers, how to act in extraordinary situations such as this one, epidemics, because to a certain extent they're more exposed, and other situations, for example, floods and earthquakes and so on. It's also what's important is to recognize informal caregivers, on one hand, who give care to people with disabilities, and on the other hand, also who give care to the elderly. But it is important when you have something which is defined by law, but the implementation of such a thing in every local community needs to be as such, so as to take into account the size of this population, but also to enable access to all types of rights which are guaranteed by the laws of this land. That would be all from my side. Thank you very much.
Izvinite, ne mogu baš da budem toliko brza da se
Wasn't
isključim, prekinem sa
turn
šerovanjem.
everything off the sharing and everything.
I Milutinu
Thank you,
hvala i
Milutin,
Nataši.
and thank you, Natasha.
Ono što bih ja samo dodala,
What I'd like to add
to je da
is that
u Švajcarskoj se
in Switzerland,
procenjuje da
it is
na godišnjem
estimated
nivou
that
vrednost
at the
neformalnih
annual level,
neformalnih
the
negova,
value of
odnosno
informal
rad
care
neformalnih
or
negovatelja
the work of
se
informal
procenjuje na
caregivers is
20 do
estimated
12
at 10
milijardi
to
švajcarskih
12
franaka godišnje.
billion of Swiss francs per year in the United States.
2013. tada
In 2013, this was estimated as $470 billion. So these are the numbers,
doprinos neformalnih negovatelja
but the contribution of informal caregivers cannot be measured. There are some things that cannot be quantified, and that is that they allow for a dignified life to millions of people around the world, whether they're chronically ill or elderly or persons with disabilities or children with disabilities.
mi moramo zajedno
So
raditi na
we
tome
have to
da
work
im damo
together
osjećaj da
to
im
have them
sistem
recognized as a
nešto
part of the
može
system, because
popraviti
some things
saveti novcem.
just cannot
Evo, mi
be
smo
expressed
postigli
with
najosnovnije
a
rezultate.
financial value. So these were
Zajedno sa
the
više
basic
švajcarskih
results
udruga.
that we presented. We have a lot
Nadam
more
se
results.
da, evo,
And I
ja
hope
sam
that,
dobila neko pitanje,
I
ako
think there were
ima
questions.
neko još pitanje
So if you have any questions, please, we are here at your disposal for the questions that you may want to ask us. Okay, Brankica would like to ask a question. Brankica Jankovic, the Commissioner for Equality in the Republic of Serbia. Yes, Brankica, just unmute your microphone. Thank you, Natasha. Yes, I was looking if we were going to raise hands. Okay, so we can do it like this as well. It's not a question, it's a comment. I hope you allow comments as well. First, I'd like to congratulate both you and the other researchers on such a truly deep and comprehensive analysis that provides an insight into the real situation, but also on the few characteristics that you added that pertain to the value of the work of informal caregivers. I think this is something that should be given far more attention to. I think that we don't have a forecast of what this value is in Serbia, but it wouldn't fall behind either the United States or Switzerland. I think that if in these results, what is good is that we don't really need to say much about it. After some research, there's a gap that that you can comment on what we need to do, and then we bring our own judgments. But I think this would be a dominant picture in all of us who have seen your results for the first time, that the first reaction, the initial reaction is a sigh, because you can see when you see this data summarized and systemically presented like we have now, what we need to do in the upcoming period. Although nobody has any detailed picture, recommendations are excellent. I would back every one of them. But the scale of burden on informal caregivers are such that they require a lot of more attention from the society. And the problem with COVID-19 that has hit us all has perhaps laid it all bare and shed some light on this problem. One of the first recommendations of the Commissioner for Protection of Equality at the beginning of the state of emergency was to ensure normal functioning of informal and formal caregivers, because at the beginning, the measures were such that they actually forgot about the caregivers. We forgot when there was a ban on prohibition of movement. We forgot about these people. So all the organizations of civil society, of which we have many here with us today, you can see what the numbers are saying as well. From the number of participants today, just how many of us we are who are interested in this and what the need is for finding adequate measures. There's no dilemma here. The scope of providing informal care speaks to the interventions going towards the labor legislation. I spoke at a conference recently that talked about the private and business life, and that usually recognize care of children and talk about the gender imbalance. But even here, the informal caregivers are not recognized in a proper way. Not informal caregivers for the elderly members of the family or for others in the family who might need different types of support. So this is a great job. Thank you on behalf of all of us. And thank you to the Population Office of the United Nations because they support this topic and keep them as a priority. So as a premier now, this is my new mandate started on Friday, the 27th of November. This is my first public performance within the new mandate, and I see this as a sign, because my first mandate started, many of you may actually remember, I can see a lot of you here that I know, and you're here, Natasha, from the Red Cross and the other organizations. and Mrs. Satric is here, and I don't want to list all the people that I see on my screen. We started my first mandate with the public hearing on the discrimination of the older persons in the assembly. So I'd like to announce for the first time that in cooperation with the Population Fund of the United Nations, next year we will submit a special report on the position of the older persons, which will be a comprehensive document, where we will also show your research, but also the research of all the organizations of civil society that have been working on this issue with a lot of dedication for many years. I think it's important to show this research to the members of the parliament. This is an important issue, and we should get some broad support so that the executive government would think very hard on what they need to do to facilitate the lives of all of those who are now informal caregivers and those who will be informal caregivers in the future. Thank you all. Thank you, Brankica. I just want to say that this is just a brief summary of the most basic of our recommendations. The recommendations are far more detailed and longer. And like Milutin mentioned, when it comes to COVID-19, the law on decreasing the risk from disasters and on emergency management, in Article 7, we talk about human rights and equality, and Article 36 talks about the right to information. And then finally, we got the results that showed that informal caregivers and all other at-risk categories were not sufficiently informed. Like Milutin said, what happened? We also saw that there's a sector for emergencies, that they made this really good family manual for emergencies, but without outbreaks, so no healthcare risks. So there are some good things there, but there are some improvements that need to be made. Risks are definitely underestimated and insufficiently recognized, but I think that this health risks, but I think this will provide a new stimulation. Dragana Dinic, yes? So, hello everyone. And I'd like to give you a piece of my mind about the results that we just heard from the angle of an assistant informal caregiver for over a longer period of time, but also someone who sees the situation of other informal caregivers that I communicate with. The issue now during the pandemic is that regular healthcare has been pretty much canceled, and it's made more difficult the life of the informal caregivers that was already complicated. For example, if you're taking care of dying patients, this has been rendered even more complicated. Maybe we should think, now this is a problem from the first-hand experience. We have seen that most informal caregivers come from the family members. But the fact is that maybe this should be recorded somewhere, perhaps in the fund that provides assistance for others' care and assistance, and also maybe with the family doctors that are there to prescribe the numerous drugs that these patients take. So there's a knowledge that we have these patients to whom care is provided within their homes. Is there any service that would, at an annual or five-year level or whatever level, would actually go to these households where this informal care is provided and see what is going on? For example, you say that only one informal caregiver went for help to a psychiatrist, saying that they had a problem with mental health due to long provision of informal care. Can someone actually go to these informal caregivers and provide some advice? Because they don't know where to go. Often these are illiterate people. Can I just answer the first part right away? Yeah, we provided the scale and we actually made those recommendations. One of the recommendations is, but again, like I said, we couldn't actually present all the recommendations here because we didn't have time at this meeting. But one of the recommendations is to collect the data on the types and characteristics of care. What you asked will be in the recommendation, but I can't actually answer whether there is an institution that will be competent for this. So these are recommendations that we will send to decision makers in order to improve the life of informal caregivers. That's the answer to your question. Well, yes, we should form a team at a local level that would, from time to time, whether that will be from the Center of Social Protection or Healthcare Center or Red Cross, whatever. But they should come and see. They will recognize as professionals what they need to advise as support in the situation they see in the field, whether it's respite or maybe application for additional assistance or for anything else. Sorry, all of this is in the recommendations, including the micro grants. You will see that in the recommendations. So just one thing. One of the key recommendations is that we need to get rid of this naivety and we should all grab hands, take hands and sing in the sun. There are services on one hand that will be clearly defined in the informal care sector. So like Natasha said, there's data on the informal caregivers that would be formally recognized and there would be a database on them. And also what is important, their needs are just not symmetrical. So if you're 18 years old, you have one type of needs, and if you're 50 plus years, and and most often this is the case, if you're a woman, you have a middle-aged woman, you have children, you have elderly parents that you need to deal with. That's a different type of burden. Also, if you're an elderly person yourself and you're taking care of your partner or your mother, or however, people are living longer and longer now. So this is a third profile. So there are certain profiles that we need to consider in terms of different needs. But the idea that this should become a formal service, a piece of the formal services, is what we're discussing here. Are there any specific questions, additional specific questions related to research now that we are all here? Maybe someone from abroad? You can also ask the question in English and we'll translate it to Serbian. If not, so I'd like to thank everybody. Thank you all for setting aside the time to hear the results of our research. Especially, like I said, thank to Susan Summers, who got up at 4 o'clock in the morning or even earlier to be with us today. I'd also like to thank Celia Levin and everyone else from the Austrian Red Cross and Albanian Red Cross and the Red Cross of Montenegro. I don't want to forget anyone. The International Federation of Red Crosses, the Italian Red Cross. I would also like to thank Chris from, and also Croatian Red Cross, and Chris McHammer, who from the Help Age International. And I'd like to apologize if I forgot anyone from all of our friends who are with us today from abroad. It's not intentional, but thank you very much for being with us today. Maybe we can have as a new topic gerontology. Okay, we'll see about that, Dragana. It's not a topic for today. But it's not just for you, it's for everybody. Thank you very much. Goodbye, everybody. Goodbye, and thank you for your attention.